Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Kimberly Miller. In today's episode, we discuss practical strategies to overcome barriers to RSV vaccination in post-acute and long-term care, including navigating insurance and addressing vaccine hesitancy. I'm joined by Dr. Jewel Mullen, Associate Dean for Health Equity and Associate Professor of Population Health and Internal Medicine at the University of Texas, along with Dr. Dallas Nelson, Professor of Medicine in the Division of Geriatrics and Aging at the University of Rochester. This episode is part of a larger educational program titled Addressing Key Challenges to RSV Vaccination in Post-Acute and Long-Term Care. For more information on Drs. Mullen and Nelson, along with a link to the larger educational program, please visit the show notes for this episode. Now let's get started as we hear from Dr. Nelson.
So let's do a little background. So first, we're going to go over the ACIP 2024 recommendations around RSV vaccines. So there are 3 FDA-approved RSV vaccines. There are 2 recombinant vaccines, and those were the first to the market. There's the RSV Pre-F and the RSV Pre-F3 vaccines. And new to the market is an mRNA vaccine, but all of them are the same dosing, 0.5 ml IM. And the new recommendation in August of 2024 is that a single dose of the RSV vaccine is recommended for all adults equal to or greater than 75 years old, and for adults 60 to 74 years old with increased risk of severe RSV disease. There are no formal recommendations for adults under 60 years old, and that's going to be continually reevaluated. The significant change, and I know if it made a big difference in my practice, is they dropped the shared decision-making mandate that goes with that. So who is at risk for a severe RSV disease? There's the chronic lung disease, the chronic cardiovascular disease, heart failure, and coronary artery disease, moderate or severe immunocompromised conditions, chronic hematologic conditions, certain neurologic disorders and neuromuscular disorders, endocrine disorders, and they're primarily talking about type 2 diabetes, severe renal disease, or end-stage liver disease, those with other underlying conditions, and those primarily they were calling out obesity with those, and frailty and advanced age. But for the purposes of this, I'm calling out those who are residents in long-term care facilities and nursing homes. So the AICP recommended that this can be given all year round. However, I would mention that there's an RSV spike early fall, so that's a high yield time to really focus on the RSV vaccine. And it should only be given to those who have not received the RSV vaccine previously. And so it's not an annual campaign.
You know, as an internal medicine doc, always have paid attention to flu and then more recently COVID. But when we consider that the CDC data is demonstrating that only 18% of adults in long-term care facilities have been vaccinated for RSV, there's a huge opportunity there. We're hoping that this elimination of the shared decision-making recommendation, along with having even more knowledge of the science around RSV vaccination, is going to help increase RSV vaccination rates. But knowing that, we also understand that people perceive a number of barriers to vaccination. So let's address barriers. So navigating vaccine payments, workflow, and reimbursement challenges. We've had a lot of conversation about this, and in part that relates to understanding the ABCDs, et cetera, of Medicare and understanding what gets covered. And as a non-long-term care provider, it's been important to me to pay attention to Dallas a lot because she lives this every day, and to really differentiate what Medicare A and B cover alongside what Medicare D covers. So Medicare D covers RSV vaccination along with Tdap and shingles. And what we have been really trying to stress is that it's one thing to think about the coverage for the care in the facility as opposed to the coverage for the actual vaccination, which is where we split out Part D, which covers administration costs, And because our presentation this morning really focuses on post-acute care and long-term care, we have the reminder that there are a number of people that you have as patients or residents who come into post-acute care who aren't even receiving Medicare D yet. So that takes us to some other considerations about who's going to pay. Okay, so in post-acute care, the actual care is covered by Part A for Medicare. Long-term care, the care is covered by Part B. And in both circumstances, Part D covers the vaccine. You may have residents who are not receiving Medicare Part D, in which case gets the extra complexity of exploring their specific insurance, including Medicaid and what will be covered there, since you may also have people who have Medicaid and Medicare D. What I would say is this takes lots of communication between the nurses, the pharmacists, and the other clinicians.
Right. So Medicare Part D pays for the RSV vaccine, no matter whether you're in post-acute or long-term care. And it's important that we figure out how to do this because it really does translate to benefit for our residents. So you want to incorporate it into your program, working with your entire facility. You can see that those 60 and older, and most of you probably experience this, when they get RSV, it can set them down a terrible cascade with hospitalization and then all the things that come from that. So it is important to vaccinate them against RSV. So I think you need to work with your facility. I would start with my infection preventionist and talk about how we're going to work on that. And one of the first things you do, because it's not an annual vaccine, you have to figure out how to determine who has and who has not previously had the RSV vaccine. And then how you're going to work through getting the vaccine for those folks. So you then need to talk to your long-term care pharmacy about how they're going to receive your orders. I will tell you what we had to figure out the first year, because it was very difficult, particularly for the Part A's. We had to talk to the pharmacy about how we were going to determine which of the two vaccines was covered by insurance, and we had to know that. So we had to put a test charge, have them turn off their Part A, allow it to go to D, see if it was covered, write the prescription, and then they would dispense the vaccine back to the facility and we would administer the vaccine. Pharmacy would get the cost of the vaccine and we would get the administration fee for the nursing home. It's a lot easier when the person is a long-term care resident, not on Part A, because it will automatically go to Part D for those residents. But the Part A is particularly tricky. So what you have to do is definitely have a conversation with your long-term care pharmacy. But also, a lot of people don't know about RSV vaccine, so you're going to have to do some education. You're going to have to do some education with your staff and facility about the importance of the why, what's in it for them, the hospitalization rate, all of that, the importance to your residents. And you're going to have to talk to the residents and their families about that. And the nurses, why they should be doing all of this work. What is the meaning of it? You also want to have policies and procedures for administering the RSV vaccine. I really use the state databases on vaccines a great deal. And that's one of the first ways I determine whether they have previously gotten the RSV vaccine is to look in the state database. If the pharmacies are doing well and putting data in there, that's a good source. I also have to trust their memory oftentimes. Most of my residents or their families can tell me whether they previously received it.
So you might admit someone who's already had it or not. So are you also doing anything as a resident enters a facility to?
So I think that vaccines are the easiest quality measure to improve in your facility as a medical director, right? And it's important you get that done early in their admission. You're getting measured on their influenza, pneumococcal, COVID. So I have them checking the state database on vaccination, and I have one person assigned to do that for every admission. Luckily, we can get some more additional database information from our EMRs that feed whether the primary cares, and we try to reconcile all of that. We have a process for that. It's very, very useful to look all of that up. It's not just the RSV, right? I'm looking up all the rest of them too. All right, so we're going to talk about hesitancy.
Vaccine hesitancy. For a while, I told people I wouldn't even use those two words anymore because they were such a conversation. Nevertheless, the whole issue of helping people move into the confidence phase to one, recommend vaccines as providers, administer them, and then to work with people and their families to receive them is huge. And there are so many different factors that influence decisions about hesitancy or decisions to get vaccinated, some of which are the contexts in which many of us live, our society lives, but also local and community norms, expectations, trust for medicine, public health, healthcare, but also individual and group preferences, and then issues around vaccine and vaccinations, which is all important to take all those into consideration because people are on a continuum oftentimes in their decision-making about getting vaccinated. And I always said that if you see somebody walking towards you, don't see vaccine hesitant stamped on their head, and understand that many people are in some place of needing more information, readiness. So I also don't write people off if they say no the first time, but try to understand how to get them closer to where they make a decision for themselves. And this 5Cs framework that looks at many different reasons that people choose or choose not to get vaccinated and how to then address those issues reminds us that it's really important to establish trust with people. And so while I've talked with colleagues who say, I just tell my patients what to do and it works for them, it's not what most people want. But establishing trust in the conversation and understanding what people want to hear helps them be more confident that you're going to give them information that's really geared to them. The complacency, who's had to address people saying, I never got it or I didn't get that sick with regard to the flu or any other condition, and then to think, stressing the importance of the vaccine because what it's going to help people continue to do or not lose as opposed to just the doom and gloom scenario if you don't get vaccinated is helpful. To really be in a conversation and not a lecture so that you do take time to hear what people's concerns are and address them. And then to think about the convenience, because in many circumstances, people might count themselves out because they perceive barriers such as cost or other issues related to access. And then the context in which we're talking with people is also very important.
RSV is very important to the older adult population. An interesting study compared community dwelling older adults to those who live in our senior living facilities, and risk of hospitalization for the population in the assisted living and nursing home is significantly higher than the community dwelling, which is why we're focused here on making sure that the long-term care facility residents are vaccinated. So co-administration is considered to be acceptable with the RSV vaccine. This was very much studied with the RSV pre-F and the seasonal flu vaccine. It's considered both safe and tolerable and resulted in non-inferior immune responses to both vaccines. The RSV pre-F3 was studied with shingles in a top-line phase 3 clinical trial with co-administration, resulting in, once again, non-inferior immune responses to both vaccines, and it was tolerated. The mRNA vaccine was studied with both influenza and COVID vaccines, and the safety and immunogenicity data in the phase 3 trial supported co-administration. So one day we may have a fall triple vaccine and mRNA, who knows? We'll see. So co-administration, that can be useful in your facility. It depends. With the billing complexities, it can be very useful to have a pharmacy come in and administer the vaccines because they get both the medication and administration fee, but they can come in and then they can take some weight off of your facility if that's convenient to your facility and what they want to do, and do your influenza and your COVID. And that's considered to be an acceptable practice. You may have folks, though, who don't find co-administration acceptable, and you wouldn't want to miss the opportunity to protect them for a co-administration. So if you can, just decide what's good for your facility and your patients. There is no interval needed between vaccines, and I have seen facilities say that you must have a 2-week. COVID somehow starts bearing down on the community, and they're like, no, we can't. Just gave influenza. That's not actually in the data anywhere. So you can be responsive to the risks in your community. All right. So We're going to go over some take-home points of the RSV vaccine. The RSV pre-F and the RSV pre-F3 are the recombinant vaccines, which are similar to the technology in the influenza vaccine. And then there is the mRNA vaccine, which is similar to the COVID vaccine that we're most accustomed to. All are approved for those adults 60 and older. And in adults 60 or older without immunocompromising conditions, RSV vaccine has shown an efficacy of 80% for preventing hospitalizations and 81% efficacy against ICU admission, death, or both. And the ACIP recommends a single dose of RSV vaccine for all long-term care facility residents age 60 and older. And co-administration of the vaccine can be done with both influenza and COVID-19.
I think we especially want to stress that risk of complications and lower respiratory tract infections among older adults, especially those over the age of 75, is a compelling reason to want to amplify the protection among the residents of your facilities. My husband's a retired pulmonary critical care doc, and I showed him yesterday a graph of RSV incidents over the past several years. And he looked back at 2016, 2017, and said, I remember that because he was in the ICU. RSV is a really nasty infection. And I think that's the perspective of someone who's dealt with the complications that we want to keep people from having to experience. And so reinforcing for all of us, and particularly for patients and families, for residents and families, that the vaccines are safe for older adults. They're safe and effective for preventing hospitalization associated with RSV, and mortality is really clear. And because I always do like to put things in a positive spin, the other thing that I also remind people is if they're protected, they have a much higher likelihood of enjoying life as they appreciate it right now than suffering acute illness and then the long-term sequelae that oftentimes befall people as a result. So RSV vaccine is recommended for adults age 75 or older, and those age 60 or older at risk of severe disease, including those who are residents of long-term care facilities.
So I have a couple questions here. There was a question clarifying whether we repeat it once a year, and the answer is no. I wish it boosted, but thus far we haven't seen that repeat vaccination boosts like we see with COVID vaccines that boost the immunogenicity. Haven't seen that. There's likely more to come for us, but this is a new vaccine. But at the moment, it's a one-time vaccine. And that being said, so it doesn't boost well. But if you had a person with an unknown vaccine status, I wouldn't be terribly afraid to err on the side of giving the vaccine. There isn't known harm from repeating the vaccine. It's just that it doesn't necessarily give a greater amount of protection.
If I may add, just because we had a question about the duration of protection of RSV vaccine against severe disease, we're waiting for more studies to give us that specific answer, although we do understand at this point that the vaccination confers at least 2 years of protection.
There is a question about payment and reimbursement. Somebody said it was 80%. We had it covered in my nursing home. I don't know if insurances vary, but it is considered preventative, and it falls under preventative care, so it should be a covered benefit. There was a question that talked about encephalitis. There is an association with Guillain-Barré syndrome. However, that is 1 in 33,000 rate for every vaccine administered. To try to understand small numbers, I memorized the incidence of lifetime lightning strikes, which is 1 in 15,300. So it's less than getting struck by lightning. At this point, it's only associated, but the causation is not clear yet. More studies to come.
Thank you, Drs. Mullen and Nelson, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program addressing key challenges to RSV vaccination in post-acute and long-term care, please click the link in the show notes. To get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.